every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
So thank you for that introduction. Most definitely I'm a nurse and I'm very proud to be a nurse. And follow on from the last speaker, if you say hopefully one day the emergency nurses will make a difference to patients' lives, I can tell you I'm sure that they already do and have. And so I think as nurses it's really important that we acknowledge and be proud of the impact that we can make in patients' lives. So I congratulate you all for the work that you do. I'm going to talk about the role of nurses and the nursing profession in ILCOR CoSTR. And as I said, I think you've heard of where I work, where I came from. I came from very much a nurse educator position and then decided to do a PhD in epidemiology, mainly because it was very research methods focused, and I believed that we needed research to be able to provide the evidence on which to base our practice. Talking about nurses in resuscitation, I do have to acknowledge Ian Jacobs. He was actually my husband and unfortunately died from a massive stroke in October 2014. But Ian was very proud of being a nurse and a paramedic, and he was the co-chair of ILCOR, the overall co-chair, not just a task force co-chair as I am, but he did make a major contribution to both emergency nursing and to paramedicine. And I'm sure that he much preferred to be seen wearing either his nurse's uniform, which up until 2010 he was still working casually as an ED nurse at Swan Districts Hospital in Perth, and he just loved wearing his paramedic uniform as well. But he wasn't the only nurse involved in ILCOR, and some of them are here in the audience today. You've heard from Julie Considine, who was on the BLS task force. Kevin's in the second row here, who's on the BLS task force. Bart Visser is actually the CEO of the European Resuscitation Council. Hilda Gunner is the Secretary of the European Resuscitation Council. Maret, you heard this morning. Maret's an emergency physician, chair of ERC, but she was an emergency nurse as well. And of course, I'm in there too. So Mary Fran Hazinski has been a real lead in paediatric nursing for many, many years. I remember when I was first a nurse educator that it was Mary Fran's textbook that we all used to use. And she has been a real great in resuscitation. She's a senior science editor for the American Heart Association. And I don't know if many of you have noticed, but together with Jerry Nolan, Mary Fran Hazinski they were both the editors of the CoSTR statements in 2015 and 2010, and I think 2005 as well. So Mary Fran's had a long, distinguished career with the American Heart Association and ILCOR, and still has a very strong role as Professor of Nursing at Vanderbilt University in the US. And just to show how courageous she is, here's a recent photo of her tackling the live crab at the Long Beach seafood restaurant. So I did promise her we'd include that photo. So back to the business of nurses, or not so much nurses, but the role of the Education, Implementation and Teams Task Force in ILCOR. I hope most of you have seen the ILCOR website, but if not, please go on and have a look. Here it'll identify for you all of the member organisations or current member organisations of ILCOR. And ILCOR is really about bringing together resuscitation councils from around the world to work collaboratively to help save lives globally. So what you will see also is the structure of ILCOR includes a number of task forces. There's actually 7 task forces that have been present for the 2010-2015 guidelines. And we're groups of individuals with representation from the councils around the world, the resuscitation councils, that get together to review the science. Our main role has been to review the science of resuscitation relating to our groups. So the 7 that have been there have been the advanced life support, basic life support, paediatrics, neonatal, education, implementation and teams, acute coronary syndromes and first aid. So the task force members for the 2015 process had representation from a variety of resuscitation councils, and as you can see, there were 3 nurses in the group. So we're certainly there, and Blair is a paramedic. He has actually just trained to be a doctor as well, but he's certainly a very experienced paramedic. So ILCOR is a multidisciplinary organisation, and so I would encourage you, if you're interested, to become involved through your local councils. So the EIT task force reviewed 17 Pico questions, and just so everyone's on the same page when we talk about these Pico questions, they're just a way of formulating a question that lends itself to the evidence review. So Pico stands for the patient, the intervention, the comparison and the outcomes. So that guides our search. And we looked at questions relating to basic life support, advanced life support, and also implementation. And I'm going to talk a little about the BLS training and the ALS training, the timings for these, because that was quite controversial, and also Suihan asked me to focus on those. So the 2 that we're going to particularly look at is the timings for retraining and basic life support and also ALS. So the outputs from our evidence reviews were published in this Consensus of Science and Treatment Recommendations, and these were published by both the journal Resuscitation and the journal Circulation. So these are really identical publications. The only thing is, for the European one, my name's listed first, and for the American one, the co-chair from North America, which was Farhan, he's listed first. So I just wanted to clarify that in case you thought there was any real major differences, but they're pretty much identical. So you can download these, even if you don't have any access to journals. You can download these from the ILCOR website over here. You just click on either of these, the CoSTR, ERC. These are the same. As I said, the only difference is the order of the first authors. And when you click on those, you'll be taken to a screen that looks like this. And if you can click on any or all of these task force outputs or CoSTRs, and you can download them. So you can see EITs down here. So let's have a look at a couple of these questions. First of all, let's have a look at what the question was for BLS retraining. So it was, among students who are taking BLS courses, does any specific interval for update or retraining compared with the standard practice, which in most of our organisations is 1 year to 2 years? Does it change patient outcomes, school performance in actual resuscitation, school performance at 1 year, school performance at course conclusion, or cognitive knowledge? Now, I will point out that we did elect as an EIT task force to actually give the highest priority in the grade process to actual patient outcomes, because I think this reinforces the concept that we're not training people for the sake of training them and getting good performance at the end of the course. We're training them because we want them to perform well and impact on patient outcomes in the real world. So I think it's important we always remember that. And when we do look for research, it would be great if we look to try to evaluate the impact of our training in the real world situation. As well as, of course, we want to see that people perform well at the end of the course. We want to see that they actually can translate those skills into real practice. But anyway, back to the question. Now, there's no real easy way to summarise the consensus on science, but despite a whole page of this, the summary of it is there's not much, and there's certainly not much good research to inform us. And this is a problem that we face in all resuscitation evaluations of the evidence, but in particular in the education, implementation and teams task force. We just don't have a lot of really relevant, strong research to base our decisions on. For example, when we looked at does any particular retraining intervals of BLS impact on patient outcomes, we found there's no evidence. There was only a couple of studies that specifically evaluated the effect of this high-frequency, low-dose training. And I'll come back to this because this is really going to be my take-home message and the way I think we're moving in our thoughts about retraining. And there is reasonably good evidence that skills decay, and they decay rapidly, and they decay way before the next update is scheduled in 2 years' time. So we can't escape that as much as we'd like to. As much as our practices are 1 year updates, the reality is people's skills degraded way before that. But the conclusion was there was insufficient evidence to recommend the optimum interval. We know that the community, we know the world would like ILCOR to say, here's the ideal retraining interval. We just can't do it. There's just not the evidence. I could have my personal opinion, and so could Farhan, and so could every member of the task force, but we can't back that up with any evidence. So unfortunately, this is what we have to say. There's insufficient evidence. However, what we can say is we know that the skills decay within 3 to 12 months, and that we really do need, if we're going to maintain that competence, other ways to increase the frequency of the training. Sorry. When you look at these CoSTR statements and you look at the treatment recommendation, I'd really encourage you to also look at these values and preferences statements, because what these are about is they will help you understand why we say what we've said in terms of the actual CoSTR statement. So I will read these. In making this recommendation, we place emphasis on the need for individuals and organisations to determine the importance of BLS skill maintenance based on their local context and the feasibility of more frequent training. The search strategy for this Pico focused on lay providers, but the results were considered to be generalisable. The EIT task force debated at length, and we did, whether to recommend a specific interval for retraining, because as I said, we all had our own ideas, but opted to leave this to the discretion of the organisations involved because the only evidence is that CPI skills decay before the currently recommended 12 to 24 months retraining. Now, we know that if we put out a statement that we believe retraining should be every 3 months, that has massive implications for organisations in terms of their obligations to implement that. And so we didn't feel we could do that, as evidence isn't strong enough. But we certainly acknowledged that there was some major knowledge gaps there. And I'd encourage you to have a look at these knowledge gaps because it does identify why we weren't able to be more specific. But if you're looking to do research and you're applying for funding, I would think it's pretty persuasive to go to a CoSTR statement and say this international body has identified that this is a major gap in our knowledge, and therefore we mean by that that we would like you to do some more research in this field. What about ALS? Well, we're any better informed there. So similar type of Pico, basically how often is retraining required in ALS? So the treatment recommendations were that compared with standard retraining intervals of 12 to 24 months, we suggest that more frequent mannequin-based refresher training for students of ALS courses may be better to maintain competence. Now, why we put the mannequin-based refresher training in there is that was the only research that we could draw on. So we really couldn't go making statements about, you need to do any other particular types of retraining because we didn't have the evidence to support that. Once again, the optimal frequency and duration is yet to be determined. So another long drawn-out statement of explanation to try to give some rationale for why we haven't been able to make any more specific recommendations. And it's got that in making this recommendation, we consider the rapid decay in skills after standard ALS training to be of concern for patient care. Refresher training in the form of frequent low-dose in-situ training using mannequins offers promise. And this is the take-home message, folks. We're moving to this concept that instead of having to take your entire workforce out once a year or once every 2 years, we need to be looking at innovative, low-dose, so short timing, but more frequent interventions to help our staff to maintain their skills. The potential cost savings of integrating these sessions into daily workflow rather than removing staff for standard refresher training may be important, and as it might reduce the total time of retraining. More recent literature in resuscitation demonstrates improved learning from frequent low dose compared with comprehensive all-at-once instructions, and a learner preference for this format. Ultimately, the question to be asked is how frequently should training be delivered? As yet, there's no definitive answer to this question because it's dependent on the type of training. For example, it's been shown in another systematic review that the use of different types of mannequins can lead to improved outcomes in the short term. However, there's a paucity of published literature, so no consensus of the task force could be reached about the specific time interval. So knowledge gaps are that we have a real limitation in the research in this area, and we really need some multi-centre studies in order to answer this question. And what we really want to know is how we could do it and how often we could do it. And what's also the relationship. Another issue that we don't know is if you're doing resuscitation practices every week, do you still need the same amount of update as the person working in a ward where they rarely see a cardiac arrest? So, what our recommendation was for training was that 1 to 2 year retraining cycles are not adequate to maintain competence in resuscitation skills. The optimal retraining intervals are yet to be defined, but more frequent training may be helpful for providers likely to encounter a cardiac arrest. There is literature starting to appear within the evidence base, and this field of research, Vinay Nadkarni, who was here over the last few days, his group is looking very much at trying to take the training to the workers rather than the workers coming to the training. So he's done some work looking at taking or having a training station set up in ICU so that when nurses are having shift changes or having what normally would be a slight downtime, well then they can go over and just do a quick 2-minute update of resuscitation, hands-on. And his group's published a couple of papers that's shown the benefits of that. And this was another paper that was for BLS nurses, so non-ICU nurses, where they just brought them in for a very short instruction on the ward. They did a practice, hands-on practice for 2 minutes, and they showed that the retention over 1 month, 3 months, 6 months was much, much improved. And they had a control group where they didn't do those updates, and there was a statistically significant difference in ability to maintain the skills. So we don't need to be doing these 4-hour updates. There's mounting evidence that low dose, short to the point updates can be really effective, but they need to be more frequent than the once or twice, every 1 or 2 years. So I think it's so important for us to all remember, my time's up. I didn't even need you to put the sign up, I did it myself. That the survival of patients does require the research, but it does require good education and local implementations. And this is particularly where we can come in as nurses to ensure that the science is updated regularly and adequately in order to improve patient survival. And how you do that really requires you to look at your local situation, because how I might implement it where I work could be very different to how you could implement it. And really be creative in how we might bring these regular, short updates to our workforce. So in summary, ILCOR's vision of saving lives isn't discipline specific. We as nurses, paramedics, doctors, all play a key role in contributing to this saving of lives globally. Nurses and paramedics can and currently do play a key role in ILCOR. The science of resuscitation is important, but so is this implementation and education. And we need to consider innovative ways of implementing low-dose, high-frequency training strategies, because we know skills and knowledge degrade rapidly. So thank you for your attention, and feel free to contact me.